Thank you. Good afternoon, everybody. Uh, it's like a homecoming for me because I belong to this place. In fact, this is my first slide. This is the 1979 batch of St. Joseph's Convent in Bhatinda, of which I was a part. I can be seen over here in the corner. So it's like a homecoming for me, and I'm grateful to Dr. Vittal for that. Over the next 20 minutes or so, we are going to discuss about the management of chronic stable angina. Now, this is proposed to be the flow of my talk. We'll first talk about definition and some bit of epidemiology, and then we'll discuss why is there this issue that you should have revascularization or no revascularization. And as I shall be discussing, there has been a recent change in the European Society of Cardiology opinion, and this has kind of brought a paradigm shift in our thought process about chronic stable angina. Now, this is a very old picture and something that we very often quote in cardiology. This is a picture by Frank Netter, and this is the first description of angina. You can see this is a man. It is cold outside. He has had probably his food, and he's walking after his food, and he's clutching his chest. So this is a typical picture of angina, and the first description of angina was given by William Heberdine in 1768, and it is believed to be a smothering sensation or tightness, and it is usually triggered by exercise or emotional stress, and may be aggravated by a heavy meal, as is shown in this particular patient. By definition, by chronic stable angina, we used to mean, I would say, that the patient has had his symptoms unchanged for at least 3 to 6 months. Then we call it as chronic stable angina because the condition has been kind of stable. So this used to be the typical definition. If you have a substernal pain which is provoked by exertion or emotional stress and is relieved by rest or by giving sublingual nitrates, then this is chronic stable angina. Now, sometimes we as cardiologists and also as physicians, we are only worried about acute heart attacks because we think that is the only form of presentation of coronary artery disease. However, we need to understand that approximately 50% of the patients of ischemic heart disease at any given point of time have chronic stable angina. So it is in fact the commonest presentation of ischemic heart disease. And the bottom of the slide actually shows the different studies and the percentages. So the range is anything between 40 to 50%. About 40 to 50% of ischemic heart disease patients have angina. So this is a very pertinent problem. In fact, it is believed that for every single patient who has myocardial infarction and is hospitalized, there are 30 patients with stable angina. So why has this issue arisen? Actually, there have been 2 or 3 trials in the last 10 years or so, and which actually raised a point that it was useless to do revascularization in the form of angioplasty or in the form of bypass surgery, and drugs were enough. One of these was a trial called the Courage trial. It showed that whether you do PCI, that means do an angioplasty along with optimal medical therapy, or you do not do anything, it did not make any difference. But then there was a lot of criticism of this study. Every day in and out, when we sit in our clinics or our hospitals, we find a lot of patients who come to us with angina. And of these, only 6.4% could be enrolled in this trial. That was one criticism of this. The other criticism was that the quality of life definitely improved with angioplasty. And the third thing was that if you quantified the degree of ischemia, if a patient has a large amount of ischemic myocardium, then there was a definite benefit of those who had a large amount of heart at risk. So then there was another study called the Orbital Study, a small study of just over 200 patients. And in that, what they did was they did a sham control. Sham control means that the patient was taken to the cath lab, everything was done except that the angioplasty was not done. So that was matched against actual angioplasty, and what they did was to compare whether there was an increase in exercise time or not, and they said that there was no significant increase in exercise time. However, the criticism was that it was a very highly selected population, and clinically significant ischemia is different from exercise time. And to top it all, 85% of the patients, those who were in the control arm, once they were out of the trial, they opted for angioplasty. So there's a big controversy going on. Important bodies in the world, like the Society for Cardiovascular Angiography and Interventions of the US, they have said these are so many points, but suffice to say that if a patient has large area of ischemia, then revascularization is beneficial as compared to medical therapy alone. And similarly, this was a statement made at another interventional cardiology meeting in Paris, that is the EuroPCR, and there also they said that the same thing, that if there is a large amount of ischemia which is provocable, then revascularization should benefit these patients. Now, till now, actually Dr. Vittal wanted me to give a write-up, but just around that time, on 31st of August, the European Society of Cardiology has made a statement in which they have changed a lot of concepts about chronic stable angina. These used to be the part of the statement of European Society of Cardiology, but there is a paradigm shift, as I said. On 31st of August, and just about 2 weeks back, the statement was released, and it said that there is nothing like a chronic stable angina. There is nothing stable about angina. It is a chronic syndrome. So now they call it an acute coronary syndrome, which means you have unstable angina or you have a myocardial infarction, and you have chronic coronary syndromes, which may be stable, relatively stable for some time, but it is a chronic coronary syndrome. These are the 6 categories of patients of chronic coronary syndrome or chronic stable angina, which we cannot get away immediately. We typically have patients who are asymptomatic but are detected as at a routine screening. There may be people who have typical symptoms. They may be having typical stable angina symptoms with or without breathlessness. Sometimes we have atypical presentation of patients who present with heart failure. And then we have patients who have either had a myocardial infarction, had an angioplasty, or had a bypass surgery, and up to 1 year and beyond 1 year. Those are the different categories of 6 different categories of patients of chronic coronary syndrome. And another thing to understand is, traditionally we used to say that chronic stable angina is a low mortality entity. It causes low mortality, but it has now been understood that based on the risk factors, that is whether you have associated hypertension or not, diabetes or not, what is your age, do you smoke, are you sedentary in your lifestyle, are you obese, based on all the risk factors, the mortality can be extremely high and it can be low mortality also. So it's a whole spectrum of mortality, and all chronic stable angina is actually not a low mortality situation. The steps in the diagnosis, this is perhaps the most important slide that I have to share. So there are 6 steps. The first step is to rule out that your patient has unstable angina. Please remember that if your patient has a recent onset angina within last 8 weeks or so, and he has a class 3 angina, then this is an unstable angina. This qualifies directly for coronary angiography. All other patients of chronic stable angina would fit into chronic coronary syndrome. The second step is to consider the comorbidities. As I said, diabetes or no, hypertension or no, smoking or no, obesity or no, sedentary lifestyle or no, life stresses or no, change of job, etc. Then we do certain routine investigations in step 3, which is doing an ECG, the biochemistry, chest X-ray, and in some patients echocardiography. Based on these, we make what is called as clinical likelihood of the patient having coronary artery disease. Further, in those patients in whom we are not sure whether this patient has surely got or possibly quite surely got a coronary artery disease, we do tests. The tests can be of two types. We can test the anatomy. We all know that a lot of people are fond of CT coronary angiography these days. So you can do anatomy test, or you can do physiology test in the form of stress testing. What is important is that we have been using stress ECG, or the TMT test as we call it, for the routine diagnosis of coronary artery disease. That does not hold true. The current recommendations are that you use exercise testing for seeing the exercise capacity of the patient, seeing whether he develops any arrhythmias because of that, exercise prescription to the patient after a heart attack, but not for the diagnosis of ischemic heart disease. However, in a resource limited country like ours, it continues to play a role even in diagnosis. And the last step is to choose the appropriate strategy. So this is how the pre-test probabilities used to be prior to the present statement. So we used to have low pre-test probability, intermediate and high pre-test probability. So if your probability used to be high, then the patient goes directly for angiography, and if it was low, most of the patients were said, okay, you don't have a heart problem, and intermediate used to go for non-invasive testing. That used to be the thing. Now, there is a change in the thought process. What the European Society now recommends is that if your pre-test probability is less than 5%, then you send the patient home. You tell him, look, there's nothing wrong with you. You go enjoy your life and just take basic lifestyle modification precautions. If the patient is more than 15%, then these patients are the ones in whom you need to do non-invasive testing. And in those patients in whom the probability is between 5 to 15%, you make your judgment based on the risk profile of the patient. And what are those risk factors? These are the risk factors that are given here. And therefore, thereafter, what we do is routine biochemistry, which should consist of full blood counts, kidney function tests, lipid profiles, and sometimes thyroid profile also for the management of coronary artery disease. Now, talking of the reversibility testing, this is what is known as the Ischemic Cascade, and we can see that the earliest thing that we can detect is actually perfusion abnormalities, which means doing a stress thallium scan or stress MPI scan as we call it. Then if we don't have that in our town, then we can go for stress echocardiography. And stress ECG comes very late. So though we can use it for diagnosis, but for diagnosis it is probably already too late and a lot of patients will perhaps be missed. So ECG is recommended for exercise tolerance, symptoms, arrhythmias, BP response, and event risk in selected patients. It is not recommended for the diagnosis of coronary artery disease anymore. That is one big change that has occurred. So based upon the profile of the patient, you can choose between an anatomy. That means you can recommend your patient to undergo a CT coronary angiography, versus you can ask them to undergo a stress echo, which I'm sure is available within our town also. And we can also ask these people to, if stress thallium or stress MPI scans are available, they are to be done. Those patients who have high risk features in that, they should undergo invasive coronary angiography, and the higher risk patients in them undergo revascularization. So as I said, your clinical likelihood, then your non-invasive testing, and based on that you categorize your patients into low, intermediate and high risk, and those who are moderate risk or intermediate risk, they undergo all these testings: CT coronary angiography or a nuclear scan. And these are the different tests which are given here. These can be used for deciding which are the higher risk patients, and based on that we make a decision. Now a word about CT coronary angiography and why it has caught up the attention. There was this study called the Scott-Hart study. Several thousand patients enrolled and followed up for a number of years, more than 5 years follow-up. And what it had shown was that if you added CT coronary angiography to the standard care, then there was a definite decrease in the coronary heart disease deaths and also in non-fatal myocardial infarctions. So you decrease the chances of death and heart attacks if you use CT coronary angiography. But the current consensus is that among the relatively lower risk patients, where you want to rule out coronary artery disease, please use CT coronary angiography. In those patients in whom there are associated risk factors and the risk is intermediate, you use reversibility testing. So based on these tests, we divide these patients into low, high and intermediate risk, and these are some of the features. For example, if on exercise testing there is a high exercise score, then your patient has a high cardiovascular mortality. Likewise, if more than 10% of the heart is at risk, it is a high risk patient. If on stress echocardiography more than 3 of the 16 segments are involved, it is again at high risk. And if on CT coronary angiography there is a left main disease or a proximal LAD disease, these patients are at high risk. So this is in a nutshell that you check whether your patient has anginal symptoms or not, you document what is the degree of ischemia, and depending upon that, those who have a higher degree of ischemia undergo revascularization. So the treatment of angina consists basically of 2 parameters. One is relief of angina and the other is prevention of progression or events, and also to try and reduce the mortality in those patients that we can. These are the basic lifestyle interventions that we need to do. Ask your patient not to smoke, to have physical activity. In fact, there are articles now to say that smoking, they say sitting is the new form of smoking. We have people who just keep on sitting for hours together. So it is said that if you keep on sitting for more than 6 hours at a stretch, that is as bad as smoking half a pack of cigarette every day. The ill effects are so much. Then there is a role of environment about which we cannot do much. I come from Delhi, and in Delhi they say that each one of us is actually smoking half a pack of cigarettes every day anyway. Just because you are breathing in the outside air, you are doing that smoke. But we don't have very definite answers for those problems. To quit smoking, there are 5 A's which are suggested. Advise to quit, assess whether he is ready to quit or not, assist him with smoking cessation, and keep following them up by rolling them into a program. Diet: eat a lot of fresh fruits and vegetables. They are extremely important. In fact, among the dietary factors, the single most important factor which is important in prevention is the amount of fruits that we eat. Not even the vegetables, but the amount of fruits that we eat are the most important. Now, traditionally, the view on medicines for chronic stable angina has been, very tight compartment opinion. We used to say, okay, what I was taught in my medical college was class 1 agent is beta blockers. Class 2 agents are nitrates, or if you can't use nitrates, then you use calcium channel blockers. So then there would be other drugs which would be called class 2 or class 3 drugs, such as nicorandil, ivabradine or ranolazine. So these were all in tight compartments. However, what has happened now is that there is a change in thought. There is nothing like a first line drug or a second line drug or a third line drug. What they say is based on the clinical parameters of your patient, whether his heart rate is high, whether his heart rate is low, whether he has LV dysfunction, whether he has low blood pressure, you tailor make your therapy. So this is what is called the diamond view of management of chronic stable angina. So we can see there are 7 categories of drugs: beta blockers, ivabradine, calcium channel blockers, drugs like ranolazine and trimetazidine, nitrates and nicorandil, which are vasodilators, and calcium channel blockers like diltiazem and verapamil. Except for combining beta blockers or ivabradine with diltiazem or verapamil, we can use a combination of all these drugs. And this decision is based on what is the kind of angina that the patient has. Many a times you would find that there are young women, young means 30 to 40 years of age, they come to you with very classical angina. You do a TMT test, that test comes out to be positive. In them, even if you do a nuclear scan, it comes out to be positive, but when they go for angiography, the angiography is reported as normal. That is because these women have what we call as microvascular angina. We cannot, on angiography, we cannot see arteries which are less than 500 microns in size. So half a millimeter or less arteries we cannot see. So that disease we cannot see at all. And the epicardial arteries, which we actually see, contribute to less than 10% of the total vasculature. In fact, they say the capillaries in the heart are so dense that if you take away all the tissue and just have capillaries, they are so dense that you cannot see across the heart. So they are a very important seat of angina and what is known as microvascular angina. The third is a component called vasospastic angina, which is also like a chronic stable angina. So based on, this is an article which was published in the Nature Reviews of Cardiology last year, and this actually tells you that, for example, pick up anything. If your patient has atrial fibrillation, use beta blockers, verapamil. You should also use trimetazidine or ranolazine. But what you should not use is ivabradine and nitrates. They are going to be useless. So based on the patient characteristic, now you decide the therapy. There is nothing like a first, step 1, step 2, like that. Those concepts have been done away with. So based on your patient characteristic, you decide what treatment or what drug treatment will this patient need. In addition, we need to give antithrombotics to these patients, which presently consist of aspirin. There is a lot of thing going on the duration of dual antiplatelet therapy after a procedure or bypass surgery. However, suffice to say that for chronic coronary syndrome, we need to give one antiplatelet agent. We need to give them, lipid-lowering drugs like statins. We also need to give them ACE inhibitors and beta blockers as and when indicated. Now, those patients who, as I said, have higher risk, that means a low threshold of angina, if they have a left main coronary artery disease, or they have multivessel disease, or they have involvement of the proximal LAD artery, then they need to undergo revascularization, which can be in the form of bypass surgery, or in the form of PCI, or in the form of a hybrid procedure. Now we have realized that a lot of surgeries can be done on beating heart. So what we typically do is that circumflex is opened with the help of an angioplasty, and for the right coronary and for the RCA, the surgeon can go and do a bypass surgery. So though that kind of procedures are also available. Now, how do you decide whether it is going to be bypass surgery or PCI for stable angina? We need to remember there are two things that we base our judgment on. One is, by and large, in the diabetic population, surgery is much better across the board, surgery is generally much better than doing an angioplasty in diabetic patients. The second thing is we calculate a score which is called syntax score. If the syntax score is less than 22, then these patients can be offered angioplasty. Those who have a syntax score more than 33, they do better if there is the surgery is the form of intervention. There is at least a 5.5% mortality difference, which means that if you have 100 patients who undergo angioplasty and 100 patients who undergo bypass surgery, at the end of say 5 years, if 60 are surviving in the surgery arm, then less than 55 are surviving in the angioplasty arm. So surgery definitely has an advantage in left main disease, in those who have proximal LAD disease, and in those who have a high syntax score. In all other patients, one can go ahead and do angioplasty. These are last few slides. Both surgery as well as angioplasty, they have been shown to be better in the overall consensus. When we consider the overall trials, both surgery and angioplasty are better than medical treatment in the overall population. But for each given patient, we need to risk stratify that patient and treat him. So this is the summary of the newer concepts. First thing is, there is nothing like chronic stable angina. You call it chronic coronary syndrome. There are 6 clinical scenarios. So you have acute coronary syndrome and you have chronic coronary syndrome. There's nothing like chronic stable angina. There are 6 different clinical scenarios that I discussed, starting from an asymptomatic patient to a patient with stable coronary and stable anginal syndrome, those patients who have dyspnea or present with heart failure, and those who have had a heart attack or have undergone a procedure, so up to 1 year and beyond 1 year. So those are the 6 clinical scenarios that we have. So based on these, based on the symptoms of the patients, based on the comorbidities, and also based on associated features, we have a pre-test probability. If the patient has intermediate or high risk, if he has a high risk probability, then he goes for a coronary angiography directly. For intermediate probabilities, more than 15%, these patients go for ischemia testing. Further management depends upon what kind of disease and what degree of disease the patient has. The vast majority, we should not be disheartened by the fact that everybody will need surgery or everybody will need angioplasty. In fact, we must realize that 55% of the patients of angina are managed or are manageable on medical therapy alone. With that, I come to the end of my talk. Thank you for your attention. If there are any questions, I'll take them, please.
Thank you so much, sir. Moving further, we have Professor Dr. Kiran K. Mukta, Associate Professor, Department of Medical Microbiology, IGMC in Hospital, Shimla, and the topic is rational use of antibiotics. Ma'am, please.